I want to thank Jeremy for the opportunity to be here today. This has been a great meeting. I've learned a lot and have really appreciated the last two lectures in particular because transition is so important to all of us, I think, as pediatric urologists. I'm a little intimidated to be speaking right now because I am an alumni of The Ohio State University and there seems to be a strong Michigan contingency here. I also know I'm the only thing standing between you and lunch, so I'll keep that in mind. And finally, as the only pediatric urologist with an audience of some reconstructive urologists, I recognize that although you do see some of our successes, more often than not, you see many of our failures. And so I hope to be able to share a few things that we're trying to look at to see if we can improve some of our outcomes. I'm going to try to burn through some of the introductory slides because a lot of this has already been touched on. Spina bifida is the most common source of neurogenic bladder in the pediatric population. We all know the sequelae of neurogenic bladder. Our goals as we talk to parents are to let them know that primarily, first and foremost, we want to preserve kidney function. Secondary outcomes or goals would be to have a dry and clean patient, have a patient that's independent, and one that is free from infection. And then, we talk to them, parents, about proper bladder function. We know it's a very complex process. Oftentimes when you think of a spinal cord injury, you can isolate the exact location and predict how a bladder may behave. And in spina bifida, that just doesn't work very well. There tends to be a big spectrum. So again, the failure to store and failure to empty is sort of the way we frame our discussions with parents as well. We know that medical management, about 85% of patients with spina bifida will ultimately require long-term use of clean intermittent catheterization. Anticholinergics are an important part of medical management, and oxybutynin is really still the only FDA-approved anticholinergic in children, although we do use all of the other ones. Antibiotic prophylaxis has become controversial for preventing urinary tract infections in recent years. And surgical management measures to improve pressures and capacity, continence, and also independence. Medical management also requires regular monitoring of the kidneys with ultrasound, blood pressure measurement, periodic CMGs or urodynamic testing, periodic labs, baseline and periodic renal scans at many centers. We know that high storage pressures can lead to kidney damage, it can lead to reflux, and that kidney infections also can lead to renal scarring, particularly in young children. So our unanswered questions are, what is the optimal follow-up or imaging regimen for children with spina bifida? When should we start clean intermittent catheterization on these kids? Do we start it as newborns? Do we wait until they want to be continent? Do we start anticholinergics only when there are upper tract changes or when continence is an issue? How do we manage their urinary reflux? And even how do we assess their baseline renal function? When you have someone who has severe scoliosis and kyphosis, the Schwartz formula requires a height. How do you manage their height when they're wheelchair bound? Can we use arm span as a proxy for that? So we'll go back a few years. In 2005, there was a survey that went out to various stakeholders, including the Spina Bifida Association, the CDC, and spina bifida centers throughout the country. And it was felt that it would be helpful to create a national spina bifida patient registry with the goals of describing the spina bifida population, documenting care patterns, looking at ways to improve consistency and quality of care, and to provide an infrastructure to support research. So following that in 2009, they actually began accrual of patients at 10 centers. Another grant round went out, and in 2011, 9 centers were added. We were part of that 2011 group. And in 2014, was the next round of funding, and by that time we had over 5,500 patients from 23 centers around the country. We've had a little bit, there's a lot of areas. So this registry is not just urologic. There are orthopedic outcomes, neurosurgical outcomes that people are looking at. But particularly in urology, we've focused on a few. And one of the things that we have seen is that there is variability among centers, as you might imagine, in the management of these patients. So surgical intervention rates range from 12 to 40% among some centers. Significant factors that were found included the type of spina bifida, their mobility status, gender. Females seem to be more likely to undergo surgical intervention. Older patients were more likely. And then again, some centers had twice the number of patients with surgical intervention. There are two management philosophies as we talk about this in pediatric groups, and one is a reactive philosophy and one is a proactive philosophy. So in reactive philosophy, we'll change management and intervene when some problem arises. If a child starts having more urinary tract infections, more incontinence, if on our annual ultrasound maybe we see a upper tract change, they tend to do less frequent monitoring, and as a result, this is often less costly and less invasive. Whereas proactive, most people would do more close follow-up with frequent monitoring, aggressive use of intermittent catheterization, anticholinergics, and maybe even surgical intervention. It tends to be more costly and invasive, but it's not clear which of these strategies really leads to better outcomes in terms of preserving renal function, much less continence status. So here are the centers throughout the country that are involved in the spina bifida patient registry. In 2011, I think, various stakeholders got together to create a newborn protocol for patients with spina bifida. So there was a working group that was convened by the CDC with all these different specialties in order to define spina bifida management in the newborns. And although a randomized clinical trial would obviously be the best way to answer these questions, it's not very practical. Enrollment is very difficult when you tell a family, we're going to treat you this way or that way, and you have no choice in the matter, we're going to randomize you. And we know that from other pediatric trials in the past. And then following that protocol as a provider is very difficult if you find a patient who deviates from that. So we created a standard of care protocol that we follow that allows for deviations by the individual provider based on patient needs. The basics of the protocol, though, are intermittent catheterization in the newborn with family teaching, and then the frequency of catheterization is decreased if volumes remain low and eventually discontinued. No prophylactic antibiotics for any child except for grade 5 reflux. They get a renal bladder ultrasound right away at birth, and then video urodynamics or both VCUG and a CMG at 8 to 12 weeks of age. And then in the first year of life, we do ultrasound every 3 months, urodynamics. They have their initial study, and then again at a year of life, they get a baseline DMSA scan and baseline creatinine. After that, it's just annual office visits and ultrasounds, annual urodynamics, creatinine, and then there's a baseline GFR study as in addition to the DMSA, and we get a 5-year GFR study and another DMSA. So clinical outcomes, we're looking at development of renal scarring, development of hydronephrosis, bladder characteristics based on urodynamic findings, incidence of urinary tract infections following a strict definition, and the need for surgical intervention. We're looking at adherence to the protocol, management of suspected urinary tract infections, initiation of CIC, and family adherence, which can be a big problem in these families. It's really the first of its kind national spina bifida protocol. We began accruing patients in 2015, and we're excited to be starting to get some of the first outcomes. We published our design and methodological considerations. This is in press and not out yet. Some of the definitions that we utilized, we kept a strict definition for UTI using the River study definition. So they had to have a positive culture, they had to have pyuria and at least 2 symptoms. There's a long list of them. The urodynamic criteria were also established. Hostile bladder is patients with end fill pressures or detrusor leak point pressures greater than 40, and then detrusor overactivity with DSD. Intermediate were pressures between 25 to 40, again with detrusor overactivity without DSD, and then pressures under 25 with no overactivity were considered to be a safe bladder. So what have we learned at this point? I'll share some data with you on baseline features of newborns, which is pretty interesting. We've learned that interpreting urodynamic studies reliably among clinicians is extremely difficult. And we're just starting to work on looking at the incidence of UTIs in the neonatal period. So Michelle Baum is a nephrologist from Boston Children's, and she presented some of our initial data on baseline imaging at the World Spina Bifida Congress last spring. And what it shows is that most kids are actually born with little or no hydronephrosis at all. So you can see most of them had no hydronephrosis in the blue, and if you add in the grade 1 hydronephrosis, which is pretty mild, there's just very few kids that have grade 3 or 4 hydronephrosis, which we would consider more significant. If you look at the reflux status at that initial VCUG or video urodynamic studies, most of them have no reflux as well. And if you look at their renal scans, which has been a little tricky because there's actually a worldwide shortage of the radioisotope for doing a DMSA scan. So this is based on only 42 infants out of over 150. But most of them have no scarring actually at birth either. And so if you look at her bottom conclusion there, it underscores the importance of a proactive protocol to manage urologic care in children with spina bifida in order to preserve renal parenchyma and reduce progressive chronic kidney disease. It's some damning evidence for us to show that these patients really are start normal, and if we don't care for them properly, that they end up getting into trouble. When we look at interpretation of urodynamic studies, one of the fellows at Vanderbilt, Ann Dudley, started by looking at the faculty members at Vanderbilt, which is a well-respected institution for pediatric urology, and they came up with 20 clinical scenarios with urodynamic tracings, took their 6 faculty members, and they found that there was a strong correlation for fluoroscopic and clinical decision-making variables. So that tells us when they look at the fluoro images, they can tell you that it's trabeculated or not trabeculated. And based on pattern recognition, they can sort of tell you, yeah, I think this is a safe bladder or not a safe bladder, and this is what we should do. But when you look at something as simple as, is there detrusor overactivity or not, and what does the EMG portion of it show, there's very weak correlation. We expanded that to a multi-center, or they expanded it to a multi-center study involving the centers from our newborn urologic protocol. So 14 urologists at 7 centers, which we participated in. Again, good agreement for bladder shape. We can all say this is a smooth bladder or a trabeculated bladder. That was easy. Some moderate agreement for bladder safety, capacity, and end fill pressure. And again, we did very poor looking at the presence of detrusor overactivity and EMG synergy. The incidence of UTI in neonates is something important and something that I'm working on right now. It's important because these babies get sick. Unlike a 20-year-old who gets a urinary tract infection, some of those can get hospitalized, but you take a 4-week-old that gets a UTI, and many of those patients end up in the hospital and they look pretty bad. It's very distressing to the families. We know that immature kidneys are more prone to renal scarring. For many centers, antibiotic prophylaxis, starting on day 0 of life, has been standard of care. But at that age, we don't really know yet who are the bad actors, who's going to need this and who isn't. And again, the use of prophylaxis has been controversial. So our initial data, I don't have anything I can show you, but I can tell you that we've got over 150 patients. About 12% of those patients in the first 3 months of life had a urinary tract infection. Were treated for a urinary tract infection, but only 4% actually had a true infection as defined by our strict protocol. And with that in mind, we felt pretty comfortable continuing with our protocol of no antibiotic prophylaxis starting in the newborn period. We'll continue to monitor that as time goes on. We want to know, once we have better urodynamic data, what's the incidence of UTI at 1 year of age, and can we risk stratify these kids based on their urodynamic data? I can tell you that of the patients with grade 3 and 4 hydronephrosis, which was a small group, that half of them had a UTI in those first 3 months. So maybe we should be prophylaxing those kids that have higher grades of hydronephrosis, even though we don't really know their reflux status yet. Our future directions, again, looking at urinary tract infections over a longer period of time. Ultrasound use is the other thing. We decided to start with more and get some data, but doing an ultrasound every 3 months in the first year of life is probably not very cost effective. And I think with most of these babies not having much hydronephrosis, that we could probably space those out a little bit longer. But we're, again, trying to accrue data to come up with a better protocol. Looking at CMGs, there's another of our group that's looking at urodynamics and outcomes with that. What are the predictive factors for those kids? And then longer term, continence and how can we predict kids that are going to have problems and help them with continence. So I hope you'll stay tuned for those results as they come out, and thank you for your time.